Hello, everyone. Hi, Lisa. I will turn it over to you.
Hi, Jack.
If there's anything you may need.
Okay, let's see. Okay, hi everybody. My name's Dr. Lisa Schulman. I am a LEN director in the Bronx at the Rose F. Kennedy Center at Albert Einstein College of Medicine in Montefiore. And we are a CRE within AIRP. And this topic of focusing on health systems and services, I'm really excited to get to talk about the posters and presentations in this session. We're gonna, let's see, we have 13 of us. I think we should get started. We're first going to hear from Dr. Leanne DeWalt on co-occurring health conditions of individuals with profound autism, findings across 3 healthcare networks. Hi, Leanne.
Hi, thank you. All right, I'm going to go ahead and get us started. Can everyone see my slides? Yeah, okay, great. Thank you. And so I will introduce myself. So my name is Leanne DeWalt. I am a senior scientist at the Waisman Center at the University of Wisconsin in Madison. And I also am the director of our USED here at the Waisman Center. And I am a 40-something white female with long light brown hair and hopefully a big smile the whole time. So looking forward to talking with y'all today about some of our research findings related to health conditions for autistic individuals. So we know that individuals with profound autism have been often excluded from research, particularly certain types of research. And so there is less information known about the health of individuals with profound autism, particularly during the adult period of the life course. And there's a gap where research is needed that's inclusive of all individuals on the autism spectrum, not just those who are able to self-report. And so we were interested in trying to address this gap. So we, in this study, compared the health conditions of autistic individuals who met a criteria for profound autism. And for the purposes of this study, we just defined that as those with an IQ of 50 or below. And compared them to autistic individuals who did not meet that criteria. And we also were interested in looking for differences between males and females for this study. And today I'm showing you data from the electronic health records from the Marshfield health system. And first, we identified adults who had at least 2 ICD-9 or ICD-10 codes for autism from their electronic health records. And then of those individuals, we classified them into those who had profound autism versus those who did not have profound autism. And again, this was based on the codes that were available in their electronic health records. And this resulted in a final sample of 347 adults with profound autism, which included 104 females and 1,791 adults with a diagnosis of autism in their records who did not meet the criteria for profound autism. And that included 356 females. And we focused on 7 different categories of health conditions: cardiovascular disease, endocrine disease, gastrointestinal disorders, neurological diseases, nutrition conditions, psychiatric conditions, and sleep disorders. And we were interested in 2 particular outcomes. So one was prevalence, which we defined as having at least 2 ICD-9 codes in a category. and then healthcare utilization, which was defined as the number of healthcare encounters within the category. So individuals who had codes within those categories, how many visits or how many encounters were they having for that condition? And then we conducted a 2-by-2 analysis of variance for each of these health condition categories. So we were able to probe for differences for autistic adults with profound autism versus other autistic adults, males versus females, and then the interaction of profound autism status by sex. And I will briefly summarize our findings. We found that regardless of the having profound autism, the autistic adults in the sample experienced a high level of neurologic conditions, psychiatric conditions, gastrointestinal disorders, and nutrition conditions. So over 50% of the autistic adults that we studied from their records and had these conditions in their records. We also found that adults with profound autism had significantly greater prevalence of cardiovascular disease, GI conditions, neurological disorders, and nutrition conditions compared to other autistic adults. So autistic adults who did not meet our criteria of profound autism. And we also found that adults with profound autism had greater healthcare utilization, specifically for endocrine disease, GI disorders, neurological disorders, and nutrition conditions compared to other autistic adults. So again, that was a greater number of encounters for those conditions when they had them. And we also found some interaction effects. Remember, we were probing for sex differences, and we found that women with profound autism had particularly high prevalence of endocrine conditions compared to women without profound autism, as well as autistic men. Women with profound autism also had particularly high healthcare utilization for psychiatric and sleep conditions. So they were receiving more encounters for those conditions compared to the other groups. So, and I'm excited for us to have a little bit of time for discussion, but just briefly, I will say that we found in this healthcare system that individuals with profound autism have significant health vulnerabilities, even compared to other autistic individuals. A strength of using electronic health records, like we did in this study, is that we were not relying on a sample of convenience or those who were able to come to a clinic or able to self-report, but rather we were able to use population-based real-world data of people that were accessing care. And I think this type of approach can lead to actionable healthcare insights, in particular, the need for the implementation of screening and intervention for autistic individuals to make sure that autistic individuals are included in different screenings and primary care. Just as an example, particularly for females with profound autism, action is needed related to endocrine disease, psychiatric conditions, sleep disorders. Why are these women having such a larger number of encounters for these conditions? Is it that we are not catching them early enough and so they're more severe? Is it that our treatment protocols are not as effective for particularly this subgroup, females with profound autism? So I think there are a lot of questions that remain to be addressed. And I want to acknowledge our funding and also say we're looking for postdocs. So if anyone wants to come work with us, we of course would love that too. So I will now stop sharing my screen. Thank you.
Thank you, Leanne. I want to say first that I really love the methodology. I'm really impressed by these three health systems data keeping mechanisms because we've tried to, in our medical system, pull out everybody with autism codes, and it was catch as catch can. There was, and as far as the level of cognitive functioning, that was hopeless. So I want to know your magic there, because I think there's so much you can do with data of this nature, and I'm particularly interested in the profound group and capturing this. So thank you. Questions?
Yeah, I'll go. Thank you so much. I'm also interested in learning more about this group, Profound Autism. I think Lisa has really done a great job raising awareness that we need to have more incorporation of these individuals in ARP. So I'm trying to think conceptually how that might work. So a few basic questions. One is, when you talk about nutritional disorders and endocrine, do you mean obesity and diabetes, or was it broader than that? Because in my personal clinical experience, it tends to be that.
Yeah, obesity, diabetes, but could also involve other endocrine conditions. So Lisa Cron's work, we used her sort of categories, which had many, many different ICD-9 codes and ICD-10 when you convert them. So.
Okay, and so then I guess my second question is sort of piggybacking on Lisa's, which is, I am a MD, I am a physician, and so and I do have a PhD in educational psychology, but not like, specifically neuropsych. So I was just curious about the testing or the identification of individuals with IQs of less than 50, that can you really attribute the social challenges or the criteria that will fulfill the autism diagnosis as due to autism, or is that the expected level of social functioning that you would find in an individual? That debate, I always listen to the psychiatrists and psychologists have that debate. And so do you know for a fact that these individuals have I guess, criteria or diagnostic findings that are separate from the intellectual disability, or does it matter? Like, does it matter that we clarify that or not? Do you know what I mean? I
Yeah.
see you nodding, so you know what I'm talking about.
Yeah, I think so. There definitely is an emphasis when you do an ADOS training, or that it's really important to try to understand the developmental level, and that social impairment makes sense for the level of developmental attainment or developmental age of the child or the adult. And so I think that studies that are doing really good behavioral phenotyping help us understand or answer that question well. I think for our purposes, because we were leveraging health records, right, we're not able to, we're not seeing all of these individuals, which is why we have so many of them, right? It's because we were drawing from a really large health system that had digitized records that go back 30 years. The Marshfield Clinic has a lot of records that we were able to draw from. And I think because we used the rule of 2, or that someone had to have at least 2 autism codes and 2 intellectual disability codes at separate visits, I think that helped us feel a little more confident that they probably had both autism and an IQ below 50. Now, whether or not is it really autism, we can't know that with these particular data, but I think the fact that on 2 different occurrences, someone felt the need to sort of drop in an autism code there makes me think that they probably did have social impairment that was significant, even with their level of intellectual disability.
What's also interesting is that because these are adults and that data may have been old, these are ICD or 9.
Yeah.
These are not F84,
No. These are older codes.
Old codes.
Yeah.
And when the definition of autism was
narrower. So I think that they really are autistic. That these are not adults that are getting a diagnosis or a code at 40. We have their sort of childhood history, particularly this area of Wisconsin, people don't move around a bunch. So yes, but to your point, I think that it was a narrower definition when they were diagnosed.
So it made me want to go in the direction of if you can gather data this way from systems, what percentage of these adults do have diabetes? How is their treatment of diabetes different from, let's say, individuals who don't have autism? There's so many ways to use this kind of data to look at health problems, management of actual health care for individuals with different profiles. I mean, we know we can't get some of our patients who do have that more profound, profile to even get a vaccine. So what if they need an MRI? What if they could benefit from an insulin pump?
And we see this in our longitudinal research of autistic adults as well, is that some of these procedures are so difficult for individuals with profound autism that they're delayed, and then you get, it exacerbates the problem. So.
Okay, thank you, Leanne. And now we're going to move on to our next poster and welcome Dr. Erica Phelps Nishiguchi and Roxanne Bristol from Hawaii to talk to us about describing an iterative pilot project proposal for group telehealth caregiver behavioral training in a developmental behavioral pediatrics clinic. Welcome, Erica and Roxanne.
Thank you.
Thank you.
Sorry, I'm trying to get to be able to see my presenter view with you guys just seeing the screen. And you'd think that this far after the pandemic, I'd know how to do that, and after our tech this morning, but I'm failing. But anyway, aloha and thank you all for attending our presentation. I am Dr. Erica Phelps Nishiguchi. I'm an assistant professor of pediatrics at University of Hawaii and attending physician in the Developmental Behavioral Pediatrics Clinic.
Hi, everyone. I'm Roxanne Bristol. I'm a licensed board certified behavior analyst as well as a PhD candidate in special education.
All right. So the pilot project that we are describing in this presentation is currently a work in progress. We're seeking grant funding for it. Our goal is to create a sustainable caregiver behavioral training to support families of children newly diagnosed with autism spectrum disorder in our clinic. The idea is that the training will be embedded in the developmental behavioral pediatrics clinic now and in the future as we present our data to hospital leadership. Nationwide, as you all know, wait times for initial autism diagnosis are very lengthy. In our clinic, which I joined a little over a year ago, the wait time for initial consultation has ranged from 12 to 36 months just in the last year. Parents' initial requests when they come to me for support frequently center around their children's behavioral challenges and need for learning functional skills. Although often these children are enrolled in government services such as early intervention or special education, parents report that they have not been receiving much support for how do they support their kids' behavior at home. And so they are dismayed when they come to clinic and find out that we don't provide robust behavioral support, and instead we refer on to other outside agencies, all with lengthy wait lists of their own. When all is said and done, children and their families may wait up to 6 years before they receive individualized services in our state and region. And in many cases, they might never receive services at all. And so increasingly, parent-implemented interventions are seen nationwide and in other contexts as a viable and evidence-based tool to provide more immediate support to families. And so that is why we are seeking that approach in our clinic.
Okay, so we wanted to describe a little bit about our proposed intervention. So it'll include 3 12-week iterations with interim analysis and adaptation. So the participants we're seeking will be caregivers of children that are with children newly diagnosed with the autism spectrum disorder in the DBP clinic. And our control group will be families currently on the wait list with initial evaluation scheduled in the upcoming 3 months. They will then be invited to join the next intervention arm if their child receives a diagnosis or provisional diagnosis at the time of their consultation. The intervention itself is a 12-week session incorporating weekly self-paced modules and group telehealth facilitated discussions. And then between sessions, caregivers will complete modules from the freely available Autism Distance Education Parent Training, or ADEPT, that was published by the UC Davis Mind Institute. The modules introduce parents to applied behavior analysis, or ABA principles, and skills for teaching some functional and positive behavioral strategies. So I would be the BCBA who could facilitate those weekly group telehealth discussions to really review and cement the lessons, learn from the modules, and then provide opportunities for the parents to share their successes and barriers from what they implemented with their children. And then the next slide is just a detailed text describing the image on the previous slide.
If I can get to it, there we go.
And then for our interim, oh no, we're missing text. So there's supposed to be 4 parts there, but our interim analysis between each 12-week session will include an analysis of pre and post behavior skills and parent stress indices. And then we wanted to also conduct focus group interviews of participants who just completed the intervention and really update the curriculum as necessary to relevant cultural or other adaptations to best fit the needs and strength of the population that we're supporting. And then this is just a text slide with the image description.
Including the text that is for some reason not showing up all of a sudden. All right, so our goals are threefold. First is to adapt this publicly available parent implemented behavioral intervention to serve our rural and culturally diverse patient population. Second, we hope to meaningfully improve behavioral symptoms in children and stress and well-being in their caregivers. And third is to demonstrate the utility of permanently embedding this intervention in our clinic. So actually, I saw a lot of overlap in some of our approaches and goals and that of our plenary speaker earlier. Please weigh in on questions on this slide. And we'd love to hear from you as you share your experiences, perhaps implementing similar interventions, some of your challenges, some of the solutions. We're also very interested in other suggested models of parent implemented interventions and other curricula that we might explore, and then outcomes measures.
Thank you for your time.
Sorry for all the technical difficulties. I'm not sure what happened in between creating this the first time.
Well, it was nice you had the slides that had it in words.
Yeah.
Well, my first question is, how old is your cohort of kids that are getting that initial diagnosis? And believe me, I know well that wait for that initial diagnosis, and you can't very well give a diagnosis of autism and not at the same time say, and this is what we're going to do about it.
Exactly.
Right. So how old are they?
But first, I forgot to mention in this very LEND-heavy audience that Roxanne and I are also both involved in our UH LEND, the Hawaii LEND. So the age is very variable. We don't have a cutoff age limit in our DBP clinic, and so we'll see new patients all the way from toddlerhood through 18. And I have had new diagnoses all the way from 2 to 17 has been my oldest. But the majority are within the 4 to 8-year-old window. So that is also a big challenge. And I think that is somewhat unique to our center. A lot of DBP clinics will have specific cutoffs.
Alice, I see that you have your hand up.
Yeah, I have a question and a comment. I mean, I think we're all struggling with the this issue everywhere. Here in Los Angeles, you know, the wait is up to 2 years for getting to see a developmental specialist. And it's been that way for quite a while, actually, not just post-pandemic, but even before the pandemic, the wait lists were very long here in Los Angeles because I think we suffered from a DBP shortage. It goes back to before 2010, we've had a shortage. And so I'm also our LEND director at UCLA, and our clinic is very different. And we presented this, I think, at our AUCD conference before, but our clinic, when we got our LEND grant and had to start a clinic, we deliberately did not want to start another specialty clinic that had another wait list, right? Because it was just like, it just, from the moment, it's like building a lane on the highway. As soon as you build it, it's clogged, you know?
Yes.
And so what we did in 2016 was, this was coming off of an actually MCH Healthy Tomorrows grant that I had. So I was awarded a Healthy Tomorrows grant in 2009, and it was to look at primary care mental health collaboration for these issues. So we launched in our LEND program, and we're about to launch a preventive like developmental program. So I'm just going to share it here, is a 1.5. Right. So when you talk about primary care being level 1 and developmental specialist being level 2, our LEND clinic is 1.5. So we're supporting the primary care providers to do so much more in order to address some of these issues themselves, empowering them, because the primary care provider is just like, oh, developmental delay, go. And so you and DBP are getting all comers, a lot of whom should maybe be able to be managed in primary care. But if you have if you have a payer environment where the primary care provider, the pediatrician, gets like 10 minutes per patient, they don't have the time to even talk about speech delay. So it's just like automatic go. And so we're really trying to empower our primary care providers and also calling them like LEND champions, so that I wanted one in each office to be able to be that designated person. But this September, we're also launching what I'm calling a school readiness program, which is 0 to 5 in primary care, managed by 2 primary care providers that are going to address 5 big behavioral issues where I think parenting goes off the rails. So first is fussy babies. So it's actually called Fussy Baby Clinic, which is like breastfeeding problems also. Sleep training, feeding, picky eaters, potty training, and then difficult temperament, disruptive behavior. And I feel like if I can get that squared away early, 0 to 5, and teach parents some skills in a primary care setting, then it prevents the number that comes to us in LEND clinic, and then subsequently prevent the number that goes on to you guys in DBP clinic, right? So I'm looking at the pipeline of patients that cause the line, right? The wait list, because we want you to see the complicated ones, the ones that really need to see you. And then, but I feel like at least here at UCLA, so much of the line, the wait list, are really garden variety basic stuff, So
Yes.
I don't know. What do you guys think?
Oh, I love that. Actually, I've just started. So there's an ECHO program that's pediatric general for our whole state, with a focus on supporting primary care providers on the different islands and in the rural communities. And then we also have an ECHO autism. And so I've started joining those, and we're currently trying to get CME accreditation for this presentation to support the primary care providers. Because I agree with you, so much of this that is sitting in, these parents are really struggling, and these kids are really struggling with really basic primary care concerns, really, but they have this concern for autism, and so they're not going to touch it. And so I think that supporting the primary care, and we've been thinking about how can we increase clinic in our LEND space. And I love this idea of a 1.5 potentially. So thank you so much for explaining all of that. And I'll also reach out to you offline.
I had I see that J.K. Young is asking, do you want to unmute yourself?
Yeah, Dr. Lacey, I really love what I heard about what I heard you talking about this, and I was wondering where at which point MCHAT or those SCQ type of screening tools can fit in for parents to have more clarification, or for the primary physicians to utilize those to screen? Or
I guess I see our primary care is really good about doing the MChat and MChat-R. But then once there's a concern, it's like go to our wait list. And we actually have an early intervention program that will get a DOH contracted psychologist to do an autism evaluation and get and make the diagnosis. But we're seeing that even with the diagnosis, they're not getting the therapies for a couple different reasons. One is insurance not covering services that are covered through early intervention or provided through early intervention and the DOE, so speech therapy, for example, you can only get through one of those spaces. It will not be covered by insurance, even with an autism diagnosis. And we're also seeing that they're not getting ABA or other behavioral therapy because it's not been a DBP, and people don't realize, our primary care don't realize necessarily that that DOH contracted psychologist is a diagnosing person. So insurance will recognize it, but if nobody's telling the family that they can use ABA, then they're waiting on our wait list before they get ABA, and then they sit again on that wait list. So there's a big education component, I think, that we should be doing in addition to rolling out the clinical services, because I actually think that even if we address the pipeline, we're still going to have a lot of families who need help, and being able to help in our clinic, I think will be good. Even if and we're envisioning this really as a bridge, and it's a group caregiver. So one of the things, I think we might have skipped over this one slide here, which is that we're worried that a group format, like even the plenary speaker was talking about how behavioral interventions must be individualized. And we're looking at this group format to teach some of those basic skills. And honestly, much of it would probably fit into those big five, right? Like there are common problems that many families face that I think we can probably teach in a group format, and teaching the ABCs of behavior, trying to understand the function, even if each kid's function is going to be different, like understanding that framework and teaching that framework and problem solving through that,
Yeah.
I think is helpful. And when I recommend families all the time to go do the UC Davis Mind adept modules, but only one family's done them so far in a whole year. And I think having that cohort might help families actually engage. But I'm
No,
curious yeah, go ahead.
I agree. I actually think for two reasons. What we are planning to do, and again, this has taken me over 5 years to build. Like these clinical programs are not easy to build. And the 1.5 clinic I started, like I said, back in 2005. So that took me a long time to build. But this school readiness program, I think the way to do it, because I already do a lot of this 1.5 clinical work, is for example, in a month, will have 3 different moms with kids all around 3 or 4 years old, all struggling with the same thing. And I have been dying to be able to say, can I get you 3 together so that you can talk with each other and provide some support to each other and brainstorm together, because one of the biggest issues I think is trying to get parents to be creative.
Yes.
When I talk to them about managing their child's behavior, they go to the internet and they read a ton of stuff and they don't know how to implement it. And I'm like, what I want you to do is become expert in your child. Like, pay attention. What does your child respond to? What does he like? What does he not like? Give me that information, then I can give you some strategies, right? So I told our social work LEN faculty member that I wanted to do these group sessions 2 years ago. And she's like, okay, well, I need to build up our internship program and I need to train them and blah, blah, blah. And so I told her, we're about to launch this clinical program. I hope you're going to be able to group things soon, because we're going to start being able to put together 3 or 4 families to do this group format. Because I agree, I don't think you want to bring them together and then like do a module. Like they want to talk about their kid, right?
Yes.
So it's sort of a facilitated problem solving. And once you teach them how to problem solve, I feel like that's a parenting skill for life. That'll work
Yes.
all the way from 3 and 4 years old to 8 or 9 years old to adolescence. You know what I mean?
Oh, absolutely. And I totally agree. Yeah, we're doing the modules as this is your self-study asynchronous. And then in the clinic or in the hour that we'll be having this session, Roxanne will kind of review and reinforce, and then yes, have that communication and problem solving and cohort building too. Because we hear from families all the time that it feels so isolating to be a parent of a child with a disability and struggling with all of this. And so even having that community building, I think will hopefully help. Oh, Roxanne is saying, yes, another focus of our project is the value. Go ahead, Roxanne, you tell us. You're on mute.
Thanks so much. I know we're almost out of time. Jackie just prompted us, but I just wanted to throw that out there that, we have such a diverse community here and primarily Asian community. And so there's a lot of, very unique ways that we really want to support these families and help normalize the idea of help giving them this parental support and being culturally sensitive and things that they're actually going to be able to use in their families and really honor them and their experiences. So that's definitely something. And we're so grateful for all of your feedback. Thank you.
Thank you. And I want to say on the cultural piece too, that one of the pieces that's missing from that iterative is that each of the three prongs will be, three iterative cycles will be culturally adapting this curriculum. That's really important in our community. Thank you so much, Mahalo, for all of your attention and great feedback.
Well, that's a really perfect segue to our next poster. So we're welcoming J.K. Young Willows, doctoral candidate at University of Texas, Austin, to next tell us about effectiveness of stimulus control transfer procedures from English to home language on listener responding skills for transition age individuals with ASD. And I learned some new abbreviations and vocabulary from J.K. Young that I'm looking forward to hearing more about. Welcome.
Mute. Can you hear me now? Oh,
We
great.
can hear you. Again, there's something missing from this slide.
Yeah, I can see. It's just coming
Oh,
in.
it's coming in.
Yeah. But hi, everybody. Good afternoon. And please pardon me, my somewhat suppressed voice got better from throat cold. But so my name is Jaekyung Bay Willows from University of Texas at Austin. I'm a doctoral candidate. And today I'm so excited to present my dissertation project. Actually, the title is Effectiveness of Stimulus Control Transform Procedures from English to Home Language, Listener Responding Skills for Transition Age Bilingual Individuals with Autism Spectrum Disorder. See, go forward. Trying to make it go forward. 1 second. Right. Growing cultural and linguistic diversity in the US is described with various data sets in relation to population with autism. Autism and Developmental Disabilities Monitoring Network reports there's now a new pattern of no racial and ethnic differences in ASD identification among 8 years old children in 2018. So when this presents actually the linguistic diversity. So when children with autism are being raised in a family with at least one bilingual parent, they need to communicate in their heritage language. And in consideration of reported benefits of bilingualism for non-autistic children, and also CLD, cultural linguistically diverse families desires teaching heritage language to children with autism is worthy paying attention. So with this background information in mind, I purpose my research to increase listener responding repertoires that are very meaningful to CLD families. So I asked these questions. Will teaching untrain the one-step listener responding expression in heritage language with the support of English LR in their current repertoires, will it be effective? And will the learned LR skill be generalized in at home or other settings? And what will parents' perception be of social validity of the study like mine? So the method I chose is single subject research design and a non-concurrent multiple baseline design across participants. Independent variable is obviously listener responding training. And dependent variable will be the percentage of accurate topographical responses with mastery criteria of 80%. And I'll be but I also will continue to utilize progressive prompt delay strategy, which starts from 0-second delay, 2-second, 5-second, and no prompt process. The condition phases of this experiment starts from LR cold probe, baseline phase intervention, which is teaching, and generalization and maintenance in 2 weeks after the generalization phase. I chose participants if they are formally diagnosed with autism, and if their age is a pre-transition or transition age, basically around 10 to 21, and if they also received ABA training in the past or currently, and also if they score higher in their receptive language skills in their home language, higher than the English language, but using the receptive one-word picture vocabulary test 4. So 4 families were invited and they consented to participate in this study. I have completed half of my data. 2 participants have completed, and I would like to describe my graph a little bit more. So here are 2 graphs with the 7 columns progressing phases from left to right. Begins with the baseline, 0-second, 2-second, 5-second, and no prompt teaching phases, followed by generalization and maintenance phase. So in summary of this data, teaching stimulus control transfer training using progressive prompt delay strategy worked for these 2 participants. What I mean by worked is they have shown above the mastery criteria as the teaching progressed, and they also maintain that skill throughout the generalization and maintenance stages. So during the training, if the data show the mastery of the Cantonese or Spanish LR, then our English prompt was faded. And then this graph showed that they each mastered the new Cantonese and Spanish LR, and each student maintained LR skills 2 weeks after the generalization probe. And the data points are quite way up there, which is above the mastery criteria. I have more discussion points, but I would like to just go straight into the questions for your feedback. Just any questions, but these are just my suggested questions. Thank you for listening.
Yes, thank you so much. Could you give us an example in the slide with the 2 graphs,
Yeah.
the data? What would be an example of what the listener responder is hearing?
Oh, okay. So the listener responding expressions were actually provided by families. And for Paul, what he has learned is eat your meal in Cantonese. And for Ella, she learned wash your face. So those were the LR training and they have received.
And those were what the parents wanted to focus on.
Right, exactly. So we're hoping that social validity survey has not been analyzed quite yet because I'm waiting for 2 more participants to complete to actually analyze the data. But we're hoping that in terms of content of their social validity score for the content of the study, I'm hoping they will be high because it has come from themselves, not I providing for them.
Right. Now let's go back to your question slide. Sorry.
Thank you. I actually brought this question 1 because my study is quite a specific teaching strategy with quite specific group of bilingual students, and there's heritage languages proficiency is lower than English, so I'm targeting quite specific group based on my literature reviews data, but there are students with autism from bilingual families at home, at school, who need the language services but not quite getting. So I wanted to pick your brain about what your thoughts might be in terms of spreading this type of very easy to use, easy to train teachers, and it's just my opinion, but when it comes to easy to very simple steps compared to other ABA strategies.
So could I ask a clarifying question? Is your intention that this intervention or this approach be used among teachers or among ABA providers who are providing, behavioral therapy in the community and families in their home? Like, who is your target user of?
Right, great question. Actually, for whoever can take this verbal open teaching strategies actually being used already in verbal behavior clinics. But these strategies quite simple enough for teachers to be trained to be able to utilize, even parents. So actually there's no limit in terms of who can use.
Yeah, it's a really, first of all, I like the phrase heritage language, which I haven't heard before. So I work in the Bronx, in New York, which is kind of a landing pad for new immigrants. And so we have speakers of many, many languages here. And sometimes, and families accept therapy in whatever language they can get it these days, which is generally here, English or Spanish. And the idea that could be, that's beneficial. And then, there would be ways to integrate the heritage language into the program, and that the parent perhaps could be the driver of that. Sounds very novel. So thank you.
Yeah, you're welcome. In schools, the language services will teach children English, and they're allowed to use as accommodation items. They're allowed to use Google dictionaries or even translation services, and they can actually hear or read in their own languages. But however, there are children with autism because of the misconception that from my reading that parents were advised by their doctors, pediatricians, that don't confuse them by teaching two languages, because they already have a problem with communicating and understanding. So parents intentionally suppress and do not teach their children with heritage languages. But in my broad theme of my research interest, which is a transition planning, culturally competent transition planning, research has been reported lately that how maintaining heritage language has improved their cultural identity and also their CLD families' preference of natural support means they're not necessarily going to social services to provide their children's need post-secondary. So they're more going to natural support, which means that ethnic community or ethnic church group or extended families to meet their children's post-secondary need. Even from that perception, for children, having the heritage language proficiently speak and advocate for their needs and wants could maybe not powerfully immediately impact them, but it'll eventually, as they get older and older and older, it'll really promote their cultural cohesiveness together with their families, extended families, and be even a study by K. Rainingberg addresses there are more employment opportunity can be opened up for children to have a, beginning jobs. So there are really profuse researches have been reporting lately, and yeah, so I'm excited to continue and finish this project. Thank you so much for listening and questions.
Thank you. Do we have any speech therapists among us, speech and language therapists among us? I know that ASHA really changed their position a long time ago now, maybe about 15 years ago, in terms of recommending exposure to just one language to not confuse the child, to very much promoting exposure to the languages of origin in bilingual households. And, so your work supports that from even an earlier stage than transition age or 10 years of age.
Yeah, thank you. The cognitive aspect of the differences between monolingual and bilingual children has been studied, and now the executive functioning, also that aspect, and also social aspect, like their identity or so on, is cultural identity and so on, is also getting more attention for bilingualism with autism, children with autism. So
Thank you.
thank you.
Hi, thank you so much for your, I just wanted to just chime in. I think this is wonderful work. There's some, to answer some of your questions about like the inclusiveness of your project, I think it's really wonderful that you're framing it in this lens of culture and the heritage language. From a behavioral perspective, there's some really great works out there where they did preference assessment with families who had, bilingual families, and doing their heritage language and English and seeing which one actually led to the most functional responses. So that might be something to consider in your work, or something that you can explore to see, because, we're making assumptions of what they can understand, and listener responding is such an important skill for communication. And so it'd be really great to see, what their understanding is, and being able to give them that preference of the language that they respond to most, and maybe the ones that they're soaking up at home from their heritage language. So thank you.
Oh, of course, I really appreciate that, especially those with the challenging behaviors and with the more minimally verbal or nonverbal children. We can, if data shows, then we can really implement. Thank you so much, Roxanne, and your BCBA already. That's awesome.
As Jackie pointed out, we had one less poster than the other sessions. So we have, I think, 15 extra minutes to kind of come back at our posters that we spent time hearing about. And so one group question is, how would you translate your research to impact the community? Any of our presenters want to take a stab at that? How would you translate your research to impact the community? Talking, again, implementation science, basically. Where should we insert it? How should we fund it?
I could be very dreamy and just, thinking, but if there's any way I could reach out, and once I finish my dissertation, or create a group, that nonprofit organization or something that could train people who are retired already about bilingual in the activities. And the simple LR, it's very, very easy to learn. You don't have to be even therapist, AB therapist, or BCBA. If I could just really envision them, you could really preserve your heritage language to your own grandchildren age children with autism, and teach them to, oh, give me water, or I'm thirsty, I'm hungry, or I need a cool bathroom. Those very need-based or basic needs can be met rather than, getting angry and pounding or hitting. I think there's a potentially that I'm just dreaming about it, that could be possible, reaching out to ethnic communities, ethnic leaders, even religious communities.
I like it. Force of grandparents.
I love the idea of grandparents. We at different points in time have had a grandparents network here in Wisconsin, and grandparents sometimes are the most, they're deeply committed and they have a little bit more time, right? And they're not doing always the day-to-day. And so they can become really great advocates. I love that idea.
Leanne, how about your project?
Yeah, I know we were talking a little bit earlier about ECHO and primary care, and there's so much work happening in the transition to adult healthcare for individuals with disabilities, including autistic youth. And I think continuing to do that outreach to adult primary care about including and supporting autistic adults in their practice, and making sure, that we're thinking about ways to accommodate and recognize different sensory needs, and being able to, engage in sort of standard screening for these different health conditions would be so important. I know a lot of what we're struggling here in Wisconsin is that we have pediatric providers. They're interested in transition and partnering in transition, but we can't always find adult primary care that are interested in taking on individuals with disabilities and as patients. Because there's such an access problem for everyone. So yeah, but doing more continuing education and perhaps using ECHO for those primary care docs would be great.
And how about Erica and Roxanne? How do you want to translate your research into practice?
So as I mentioned, yeah. So as we mentioned that we're in the process of writing our grant right now. And so we've been really thinking about our budget and like, what can we write into our budget that helps with the unique challenges that our families have, so that we can make sure that this is maximally affecting everybody, and particularly the most vulnerable populations, which need to be designed. We need to design this for intentionally, right? Because otherwise it's just going to reach the people that already have access to internet and can have the time to log on to our sessions and that kind of thing. And so we initially had thought about doing this in person, and immediately changed that to telehealth so that we would be a wider brand. And then we've been working on like purchasing equipment such as a dongle, which is like kind of a Wi-Fi hotspot kind of thing that we could purchase for our research project, and then give it out and bring it back at the end, and use it through each iteration, and then in the future embedded clinic. We have a budget line for interpretation, like having an interpreter for each language. I actually, in my training in Seattle, I was part of a in-person group-based training that did have interpreters for 4 different languages in a single group setting. And so I know that it is possible. And so we'll just have to figure out the best way to implement that in our telehealth. And then we've also been thinking about, just even with a dongle, like there's connectivity issues, there's the family, like getting time each week to focus on this is a big challenge. And so we are also we'll be building a community advisory board out using these mixed methods, implementation science type strategies of engaging the stakeholders, not just the families themselves, but also the primary care providers and others in the community. What are creative ways that we can come up with best supporting these families? And I think this is just one piece of a much bigger project, right? But this is where we can start small in our early career and then build up over time.
Thank you. Yeah, it does remind me when I hear about your project that we at our center here, we have a long history of parent support groups over decades, and the parents who've been in the support group and found it helpful all these years are natural navigators for the families who are just going through it. And much like we were talking about the grandparent workforce, they become we're all LEND people, they become parent or, family trainees in the LEND program. And it's kind of part of their parental course, and all the learning they've done in having a child with a developmental disability to kind of give it back to the next generation. So they're kind of an untapped expertise and workforce relevant to your parent group model.
That's such a good point. And the concept of ohana and multi-generational families is huge in our communities. And that's actually one reason that we are calling this caregiver training and not just parent training.
Nice. Any other thoughts on translating the research we've been talking about to impact communities?
I have a question to Dr. DeWald's project. Is it okay to ask about that? It's not. Yeah, I just ran out of time to ask you, but so severe disabilities, children with autism. So some of these physical conditions, are they diagnosed at the birth of their children themselves as a congenital condition or acquired as they got older? Because there's, yeah.
Yeah, so in general, most of these diagnoses are occurring later. So they were not congenital, but that's something we need to dive more into in our data and look at the timing of the age of onset and see if the age of onset is different for different groups. And so we haven't done those analyses yet, but many things like seizures or diabetes, those types of conditions, those would be occurring later. And it's hard to know how much, is related to something that's sort of endogenous about the person with autism and their genetics, and how much of it is about, the stress of being an autistic person in a non-autistic world, the medications over time that many autistic individuals, particularly by adulthood, are on many, many different medications. And so when we see these elevated health problems and these frequent health encounters, it's hard to disentangle sort of their developmental course, right? That if they were in, a different context where maybe there were different types of supports or they weren't on so many medications, would we see all of these conditions. And as I was mentioning before, it may be that particularly women with profound autism, maybe they have more significant types of these conditions, or it may be that they're not receiving the right treatment at first, and then it takes more treatment. And so those are questions we don't know. But looking at the age of onset of these different conditions, I think it's a step to try to tease that apart.
I see. I was
I
just
think
thinking. Sorry.
Erica, what would you say?
No, go, please go ahead, finish up, and then I will comment. I didn't realize that you were going.
What preventative measures we could do if there's a pattern, like certain conditions seem to, take onset on stage 5, or the parents can be more aware of, or in terms of just could be part of the parent training.
Yeah, exactly. And that so often is the family that's the constant thread across the life course, and that we're trying to build systems where people are able to access what they need and they receive the care that they need. But in the absence of our fully functional systems, whether it's healthcare, education, that providing the families that education so they can advocate within these at times non-functional systems, I think it's good. Erica, what were you going to say?
I was going to say that probably most of these are starting out in childhood and then manifesting in adulthood if they're not manifesting in childhood, right? And this is, I think, partially probably, Alice, what your 1.5 clinic is addressing, right? Like the picky eating, the sleep disruption, like all these things start so young and then they become ingrained. And with anything behavioral, like the longer that it's been going on, the harder it becomes to fix. And once you're dealing with all the downstream ramifications of all of those primary challenges, we're just in a really deep hole. And so this is one that actually in the training that I'm doing with the primary care providers is really focusing on can we get autistic kids and other kids with developmental disabilities to be seen in a chronic care model, like every 3 months, like you do with so many other chronic diseases, because all of these things manifest young and they take time. And like if I'm spending all my clinic time doing these follow-up visits on these concerns, then that's less that also impacts the wait list, right? But we have more time, right? And so I think there's this challenge, right? Primary care doesn't get enough time, but if you see them in follow-up, then you build that relationship. So
Right, so the longitudinality, I mean, I think you hit the nail on the
Yeah.
head. I also use the Wagner chronic care model as the basis for a lot of our clinic building. And the main, I mean, I hate to say that, the main motivation for starting that school readiness clinical program is the number of suicidal 10 and 11-year-old boys that we've seen after the pandemic.
Wow.
They are so
Wow.
young, but their behavior, like I have one that's chronically threatening to jump off the third floor balcony, and the police have been called to their house, 11 years old, right? And
Yeah.
so, but then the parenting, I can see it because they were my primary care patients. I've known them since they were 4, and the parents were, just always struggling with managing it's a temperament mismatch. And I'm just going to generalize, usually a mom who cannot appropriately put boundaries on behavior. And these are also the moms that really subscribe to PDA, right? Pathological demand avoidance, which I will quite bluntly say, that's a really popular diagnosis in Europe. Like it's not really a thing. But I also I can't say that because they really buy into it. But I just want to share a success story. I had a 7-year-old kiddo in my clinic a couple Fridays ago who at 4 had this issue, and the mom is a 6th grade teacher. And at 4, this kid was just ruling the household, and the mom was like, well, he's autistic, so he's got this demand avoidance, fight or flight, all those buzzwords. And so, we were touching base. Apparently things were going okay. And then all of a sudden this spring, poof, really terrible. F-bombs, breaking stuff, throwing lamps, just like completely destructive behavior in the home. And I finally got through to her in so she brought him to see me. We couldn't have a conversation because he wasn't having it. So then I said, let's just do it on Zoom with you and your husband, let him go to camp, whatever. And we had over an hour. It was like almost an hour 15. And I had to say, what is your end goal here? If you never place demands on this child, he's going to be the one that threatens someone on the playground, and then you're going to be the mom in that family meeting at school. You've been the teacher, you know what that's like. And then you could see the realization come. And then the dad was like, I think we can put some limits in at home. This kid has not had any limits in 8 years. And I said, I think if you do, the behavior is going to get a lot better. And this is what we're doing in primary care, Anyway, sorry. I see that we're about to go back.
Thank you, everyone. Amazing
Great.
discussion.
Really great presentation. Thanks. Such a great discussion.
Thanks,
Thank you all.
everybody.